All right, good afternoon and welcome to today's webinar, Medical Debt is a Public Health Crisis. My name is Daniel Wacker. I'm the Program Development Associate here at the Network for Public Health Law, and I'll be your host for today's webinar. We strongly encourage attendee participation via the Q&A function at the bottom of your screen. Feel free to click on the Q&A bubble and ask a question, and our speakers will get to answering questions at the end of the webinar. You can also ask questions in the chat, and we'll be monitoring those to bring into the question and answer session as well. Your moderator for today's webinar is April Shaw. April is a senior staff attorney in the network's health equity team. She has expertise in breaking down the policy impacts of law and illuminating how theory can inform practice. She also has expertise in racial health equity and is especially interested in thinking through how multiple inequities intersect to create systematic disparities. Some of her areas of focus include mental health, suicide prevention, cultural healing and safety, and climate justice. April earned her PhD in philosophy from the University of Colorado at Boulder, specializing in social and political philosophy with a focus on gender and racial justice. She wrote her dissertation on severe global poverty and human rights. April received her JD with distinction from the University of Arizona James E. Rogers College of Law. And I'll pass it off to April to introduce the rest of our speakers. April, to you.
Thank you so much, Daniel. I'm really excited to be here today. We have a really wonderful panel talking about medical debt as a public health crisis. So I'll go ahead and introduce some of our speakers. Our first speaker is Priscilla Thomas Keith. She started her career as a research scientist at Lilly. Upon receiving her law degree, she served as Deputy Attorney General and Section Chief of Advisory during her tenure at the Indiana Attorney General's office. She was also assistant counsel to Governor O'Bannon. Following her passion for public health and healthcare law, she became general counsel for health and Hospital Corporation of Marion County in the Marion County Public Health Department. She has received numerous awards, including Indiana's highest award, the Sagamore of the Wabash, a tribute bestowed by the governor to those who have rendered distinguished service to the state. She currently serves as RIP Medical Debts Director of Program Management. A primary focus is leading cross-functional teams from the time of medical debt procurement to its abolishment. Her areas of focus are public health and health equity, healthcare law and policy, and corporate governance and risk. Next slide. Eva Marie Stahl is the VP of Public Policy at RIP Medical Debt. She oversees development and implementation of RIP Medical Debt's policy work. She works closely with RIP staff to ensure that beneficiaries' voices and experiences are centered in solutions that address the medical debt crisis. Prior to RIP, Eva was a leader in health advocacy community for over a decade as Director of Policy and Partnerships at Community Catalyst. She was part of the senior leadership team responsible for developing state and federal policy agenda. She holds a PhD in social philosophy from the Heller School at Brandeis University and an MPA from the Lyndon B. Johnson School of Public Affairs at UT Austin. Next slide, please. Jennifer Bosco is a staff attorney at the National Consumer Law Center, NCLC, where she focuses on several consumer issues, including medical debt and utility issues. She co-authored NCLC's Model Debt Protection Act. She's a contributing author to the Collections Actions Manual and a co-author of the Access to Utility Services Manual, published by NCLC. Prior to joining NCLC, she was the first director of the Office of Patient Protection at the Massachusetts Health Policy Commission, where she ran the Massachusetts Health Insurance Appeals Programs for persons with Massachusetts fully insured health plans and administered the Open Enrollment Waiver Program. Before that, she advocated for healthcare needs of low-income individuals as an attorney at Health Law Advocates in Boston, assisting clients who were insured through Medicaid, private insurance, or who lacked insurance. She previously represented clients in legal aid organizations and holds a JD from Georgetown Law Center and a BA from Boston College. Next slide, please. Naaman Shah is a family physician and epidemiologist at the Los Angeles County Department of Public Health. He is the director of the Division of Medical and Dental Affairs, which supports innovative and just healthcare within the department and in LA County. Naaman completed residency training at Contra Costa County Regional Medical Center and received his MD and PhD from the University of North Carolina at Chapel Hill. And with that, I will turn it over to our speakers. As I said, we have a really great lineup today. Priscilla is going to start us off talking about medical debt as a public health crisis and a social determinant of health. And then we'll be looking at the law and policy issues at the federal level, state level, and then looking at it through the local level. So with that, I'll pass it to you, Priscilla.
Okay, thank you very much, April. I would also like to say thank you very much for the opportunity to talk very briefly about medical debt and its impact on social determinants of health. So Daniel, if you could advance the slide, please. We know the topic of the conversation is medical debt is a public health crisis. Next slide, please. The question is, why is medical debt a problem? Well, first and foremost, it is different from other types of debt. It is not a product of consumer choice. It is not as if you're going out to say, I'm going to buy a car, I'm going to buy a television. What this is that most people, if not all, do not choose to be sick. And so they do not choose an emergency healthcare issue, or in the opposite, have to deal with chronic healthcare issues. So it's not one in which they would choose for themselves. Secondly, as we all know, or most of us do know, that many of us who confront a medical emergency or a chronic health disease have little savings to buffer the shocks of medical bills. I do have in my slides where many households do lack $400 to $500 just in general savings. And so if a medical bill does come up, they don't have the money to pay for that. Third, in terms of medical debt, it is more prevalent in Black and Hispanic communities. And also, I would like to say with people who have less income and education, and you may find this in rural areas, so to speak. In terms of bankruptcy, medical debt is a leading cause or a major contributor in that vein, and it is now being recognized as a social determinant of health. And finally, on the slide, getting sick and not being uninsured is the biggest predictor of medical debt. Next slide, Daniel. Medical debt is pervasive. It can happen to almost anyone, but we do know in terms of the prevalence of it, it seems to impact most people who are already struggling with poor health, have financial insecurity, or really both. In terms of looking at the data, we do know that approximately $195 billion in medical debt can be found in the United States. And the Census Bureau around 2021, 2022 estimated that approximately 1 in 5 households across the country, as well as 1 in 4 where you have children under 18, have medical debt with a median amount that is owed of approximately $2,000. Next slide, Daniel. Let me just pivot a little bit here in terms of RIP Medical Debt's mission, of which Eva and I are members. I want to say that medical debt is uniquely an American injustice. It's uniquely because we find it primarily in the United States, and it prevents millions of people from achieving that financial stability, and it subjects them to emotional anguish, which I will talk a little bit more about in upcoming slides. So what is the primary mission of RIP Medical Debt? The primary mission is to end medical debt, and using a 3-pronged approach. Let's talk about that very briefly. We can and are a source of justice in an unjust healthcare finance system. Secondly, we offer a unique solution for patient-centered healthcare providers. And third, we can and we are a moral force for systemic change. So that's the three-prong approach that we have. And I want you all to remember that, our primary mission really is to end medical debt. Next slide, Daniel. Briefly, background on RIP Medical Debt. We are a 501c3 national charity, again, that acquires and abolishes medical debt for many people who are burdened by this financial hardship. How do we do it? That really is a fundamental question that people ask us. Well, we are funded by donors that include individuals, faith-based organizations, foundations, corporations, and local governments, and others. We're almost 10 years old, having been founded in 2014 by two previous debt collectors. RIP has acquired and abolished approximately $10 billion in medical debt for over 6.7 million people, and most recently received a $50 and $30 million grant from McKinsey Scott. And finally, we do have an engaged, accomplished board of directors. So we're less than 10 years old, but mighty in what we do. Next slide, Daniel. What is medical debt's impact on social determinants of health? Let's start with CDC's definition of social determinants of health. And they define it as conditions and places where people actually live, where they learn, where they work, play, and worship. And these categories do have an impact on a wide range of health risk and outcomes. So let's explore the six key areas that the CDC has defined. The first one is social and community context. How do people engage their community? Are they involved with community? Is the community supportive of what they do? And do they know what's actually happening in their community and have a voice for that? Secondly, do they have access to health care? And if they have access, do they know how to use it? Third, in terms of neighborhood and the physical environment, what does that look like? Do they have adequate sidewalks? Do they have a place where people can go and stay? Fourth, what are workplace conditions? We know that with advent of COVID, that the workplace has changed. Now it's really some people work from home remotely all the time. There may be a hybrid workplace, or now we're seeing employers asking employees to come back to work, if not hybrid, but on full-time basis. What does education look like? Is it where all things are equal, or are we still operating in a separate but equal playing field? And lastly, with the income and wealth gaps, what is the poor getting poorer, or is the rich getting richer, or is that gap getting wider? The next slide, Daniel. I want to just compare this just very briefly with the Kaiser Family Foundation in terms of the categories that they looked at, and they're mostly similar. But if you look at the fourth category where we have food, the CDC did not define food as a social determinant of health. The Kaiser Family Foundation did, but we do know that food really is one of those categories that really should be placed at the forefront, because people do make decisions when paying bills in general and with medical debt, whether they pay that debt or whether they put food on the table. And if you were to just take a snapshot or ask many patients or beneficiaries, what is, do they have access to food, or is that an issue for them? I wouldn't go so far as to say 9 times out of 10, but what I've seen in my practice is that does come up where food is an issue, or access to food, because many of the people who are impacted by medical debt live in food deserts. Next slide. I want to acknowledge this slide by the Sycamore Institute. I didn't have that labeled, but I do want to go ahead and do that and just say very briefly, how does medical debt affect the factors that drive health? And we've talked a little bit about these already, but just to piggyback on that, social and economic environment. What is your credit risk? Your credit risk will define how much you can borrow and what the interest rate is related to that. Do you have the ability to pay other bills? If your credit rate is not as good, the use of high-cost loans will impact you if you are working with a payday lender or you're using credit cards, medical credit cards, to pay off your medical debt. What is the cycle of debt? Do you feel as though you are, part of that hamster wheel that you can't get off? Are you subject to litigation? And last, because you cannot manage the situation, do you feel as though bankruptcy is the last step in the process? Physical and environment, I've already talked about that in terms of access to green spaces. Health behavior, we do know that stress causes other related issues, and that may be tobacco, alcohol, and drugs, increase in mental health issues, and then poor nutrition because you're doing trade-offs. And then with clinical care, we've already talked about access to care. And then I want to just acknowledge the financial strain on providers because if for lack of payment, we do see in most cases where rural hospitals are closing because they do not have access to the capital to keep the hospitals open. Next slide, Daniel. Implications of medical debt. I don't want to be repetitive, but the questions to ask are, do you have access to good debt? Low credit scores make it harder to access loans and enhance economic mobility. Employment, many people don't know, but depending upon the type of job you're applying for, many employers check for credit reports when making hiring and promotion decisions. Housing, again, that determines where you live, whether you can get the type of loan, the type of house that you want. And the one thing that I do want to add is that if you tell me where your zip code is, where you live and your zip code, I could probably tell you what your longevity will be, because that your zip code seems to correlate to that as well. What is the cost of debt? A good credit score equals lower interest rates. And then with transportation and utility, car loans are more expensive. You may have to pay larger security deposits, and then insurance premiums again can impact that. Next slide. I need to hurry up here in terms of timing here, but just want to highlight very briefly two studies. The first one by Professor Ray Klander from Harvard and his associates in terms of looking at a retrospective study regarding social determinants of health and medical debt. And he looked at two factors. The first one was the total amount of unpaid medical debt, and then the timing of that in terms of 12 months, and using data from TransUnion and taking a 10% sample covering from 2009 to 2020. And what were some of the findings related to that? We do know that states that expanded Medicaid, had a lower medical debt threshold as opposed to those states that did not expand Medicaid, where we see a higher incidence of medical debt. And if you looked at it from a demographic perspective, the southern states, or those states in the Southwest, had a higher incidence of medical debt because they didn't expand Medicaid. And if you were to look at the states in the Northeast and on the West Coast, you had the exact opposite. And I also want to just talk or single out that for those states that didn't expand Medicaid, and now we see a higher incidence of medical debt, think about the pressure on patients who may have a delayed prognosis because there's anxiety about reaching out to the medical community, or in the opposite, where the diagnosis has already occurred, but there's an issue in terms of it, the diagnosis being exacerbated because the patient has failed to come in and get additional treatment. So we do have evidence in terms of medical debt being classified as a social determinant of health. Next slide. And I need to hurry up here. Just in terms of David Himmelstein corroborating Dr. Calandra's information. Next slide. Medical debt's impact on health equity. We look at the definition of health equity as the states in which everyone has a fair and just opportunity to attain their highest level, but we know that this is not always true. And this includes historical and contemporary injustices such as housing, environmental discrimination, workplace discrimination, and then looking at the health disparities. I won't belabor the point in terms of households having 400 or less in terms of having to deal with or payment with unexpected medical debt. About 2/3 of those say that they have members in their household where they have medical debt, but they do have insurance. We need to look at that in terms of high deductibles, and then the far-reaching implications in terms of financial stability and the force of trade-offs as to whether you're going to eat, you're going to pay your mortgage, your rent, or you're going to pay the medical bill. Next slide. Who's most impacted? Black households, 28%, Latinx, 22%, white households, 17%, but if you put it all together, 19% of households across the United States are impacted by medical debt. Very briefly, from kitchen tables to corporate boardrooms. Next slide, Daniel. I just want to talk very briefly about the Community Impact Initiative that RIP has embarked on. And what this really means is that we made an intentional and conscientious effort to say, let's work with our community-based organizations who are on the ground, working with their communities to not only provide access to healthcare, but also having to work with those patients or constituents who have to deal with medical debt. So this type of connection connects us to established entities who are really facing this battle with communities, being able, as we learn from them, to be able to leverage those local relationships and to leverage their expertise because they know what's happening with their patients. Be able to work with them to provide a health equity solution. And then also not only in terms of the short term, but let's look at what the expansion of a long-term impact of our efforts can be on the eradication of medical debt. Next slide. If we get this right, medical debt can be reduced or eradicated. And then also in terms of the public stigma, we've learned that many people who are faced with medical debt really look at it more as a stigma than they do with consumer debt. They're really embarrassed about it. And we want to be able to reduce that while we're reducing patient costs in an upstream and finding solutions to that institutionally and through public policy change. Next slide. I'll finish here in the next 30 seconds. In terms of RIP's pilot goals, again, learning best practices for community collaboration and understanding how constituent stories and needs might support and inform policy goals. Next slide, Daniel. I think the last slide is program strategies, working with providers who are providing healthcare access to patients, understanding the data that we get and what that means with regard to research and evaluation. Third, fundraising. Let's just be honest, it takes money to be able to abolish medical debt. Fourth, looking at the public policy and making sure that we're in alignment with what's happening and understanding what's happening in those MSA areas, working with hospitals in terms of financial assistance policies regarding health systems, and then bringing awareness about the impact of medical debt across demographics. And I think the last slide, Daniel, that I do have is that, again, I just want to reiterate that medical debt is pervasive and it's rooted in inequity, that we need more awareness and knowledge about what it is in order to build powerful policy change. And then finally, the stories and lived experience of people with medical debt is important, and that we need to hear those stories to be able to spur action and that action that can lead to meaningful change. So thank you again very much for the opportunity to just talk about medical debt, social determinants of health. And I'd like to go ahead and pass it to my colleague, Eva Stahl. Thank you.
Great. Thank you, Priscilla. Daniel, is my sound okay? Because I threw in earphones. Okay, perfect. Next slide. So Priscilla already touched on RIP medical debt. I'm grateful for that, and I'm happy to be here today. Just a few more details about how we purchase debt. We purchase debt in bulk, and we have two criteria, which is that we purchase it for people that have income at or below 400% of the federal poverty level, or if a patient's debt is more than 5% of income. And we're able to sort of flip the script on the debt purchasing model and buy this for pennies on the dollar, which gives us a good robust return on investment. So next slide. And as Priscilla mentioned, medical debt's pervasive, right? Estimates out there range, but one that tends to be lifted up a lot that's drawn from census data is $195 billion in medical debt nationwide, affecting over 100 million people. Next slide. And as Priscilla noted and walked us through, medical debt's really harmful, right? And so just through the stories, but also through the data, there are a number of analyses that are out there that document the harm of medical debt, its disproportionate impact, particularly on people that reside in states that lack access to robust coverage like Medicaid. And also there is increasing numbers of studies that are highlighting the mental health harm of medical debt. There's a robust literature in the cancer field around medical financial toxicity that's well documents some of these harms that we see in the stories that we hear about every day. Next slide. So I'm going to take a little bit of time just to walk through some of the activity at the federal level that we've seen over the past 24 months, because it's been pretty active. And then I'm going to hand it off as we sort of drill down to the state and the local level. But it's worth sort of framing this up for folks. So go ahead, Daniel, next slide. That'd be great. So, starting in 2022, the No Surprises Act went into effect, right? So this was really monumental. It was a bipartisan effort to make sure that people were not feeling the pain of these surprise bills that they didn't know about, and caused a lot of stress for them, as well as led to medical debt. So when that law went live in January, the Consumer Financial Protection Bureau released a bulletin to really remind debt collectors of their responsibilities as a part of that law passage, to make sure that they shouldn't be going after people's bills, unpaid medical bills, medical debt that was associated with a surprise bill. And then shortly after that, in March, we saw the national credit reporting agencies. We call them the NCRAs. These are the big three, right? The TransUnion, the Experian, the Equifax, that they voluntarily said, okay, we're not going to report medical debt on your credit report if it's under $500. And for people that have paid their medical bills or their medical debt, we'll remove that from your credit report. So these were significant changes that were going to be voluntarily rolled out and have been rolled out since 2022. At the same time, the CFPB began to release a number of reports, literature reviews, and white papers, really documenting the harm of medical debt and some of the practices that they were hearing about in consumer complaints. And then by April, there was an announcement by the vice president around a series of changes to address medical debt. So really the administration taking a stand on medical debt and trying to do what they could within their authorities to make a difference for people every day. And this included heightening the role of CFPB to take a closer look at the issue of medical debt, particularly around collector practices, as well as Secretary Becerra from HHS saying that they would begin to investigate some of the practices in hospitals around financial assistance and do some survey work and come up with some policy solutions around medical debt. It also was important because it named what most people know is that medical debt is not a good predictor of your creditworthiness. So in other words, why should medical debt be included on your credit report if it doesn't predict whether or not you pay your bills on time, right? And then in December of that year, Senators Murphy and Van Hollen re-released a medical debt bill, which really took aim at some of these practices and these extraordinary collection efforts that were harming individuals across the country. And I just named that because it's a robust bill, but it also is not a bipartisan bill. And so there's yet to be a movement really to be in the bipartisan space on the legislative side. Next slide. In 2023, the year that we're in, it's been really exciting to see the issue continue to gain momentum. So in the early spring, we also saw a number of advocates come together across the country and push forward. They did a petition to the Consumer Financial Protection Bureau on both the issue of credit reporting, so medical debt showing up on credit reports, which is one of the #1 complaints that folks hear about, as well as the use of medical credit cards as being harmful for individuals across the country and leading to medical debt that they were unable to pay, or perhaps feeling like they were pushed into these payment products without full knowledge of what they were getting into. This was followed up in April by the Consumer Financial Protection Bureau, again, releasing a number of different white papers and reports, of which they continue to do, and it's worth actually going back and looking at their log of investigation. In August of this year, not that far behind us, the White House announced a lowering healthcare cost, did a big press release, sort of an announcement to announce a number of different measures around lowering the healthcare costs for people across the country. It included some of the things that we knew came out of the Inflation Reduction Act, but it also included a request for information from Treasury, from the Consumer Financial Protection Bureau, as well as the Centers for Medicare and Medicaid. And this is important because it really was an opening to create a public space for people and advocates and experts to weigh in regarding the harm of medical debt, with a specific focus on credit cards and the use of credit cards in payment of people's unpaid debts around their healthcare services, right? As Priscilla noted, that we have such high out-of-pocket costs for individuals across the country, particularly if you're insured and you're in a high deductible health plan. Many people across the country, if they can't afford a $400, $500 surprise bill in their life, can afford, $1,000, $2,000, $3,000 deductible. And in September, the tri-agencies closed this RFI actually on September 11th. And what it did is really create a public record that folks can actually tap into and take a look at sort of some of the different arguments, but really documenting the harm of medical debt across the country. Next slide. So while these administrative actions over the past 2 years have been significant and important, they are limited, right, in what actually can be done, although more can be done. I think a number of people on this call feel strongly about that, but it really sets the stage for both responding to pressure across the states as this sort of ticks up at the state and the local level, but also creates more pressure around the issue at the federal level, very much like what happened during the No Surprises Act, right? So they're important markers of how we're beginning to move forward on the issue of medical debt. And a lot of kudos should go to advocates across the country that have worked incredibly hard to make sure that this has stayed to the top of minds of both legislators and notably those in agencies that are able to take action. Next slide, please. And so now I want to pivot that you sort of get a little bit of a snapshot of what's happening at the federal level, that there is a lot of activity. It's also in response to what's happening both in the media and around the country in conversation about medical debt, and really positioning medical debt as a very an urgent issue, an issue that's really needs to be addressed now. Next slide, please. And so this is just an example of one of the things that's been happening over the past 24 months. This piece in the Kaiser Health News, Diagnosis Debt, has really been a set of stories that has really been significant and helpful in elevating the issue of medical debt and centering the stories of people that are carrying medical debt. And if you haven't seen this site, it's definitely worth perusing, but it's also had a ripple effect across the media in lifting up some of the stories that affect all kinds of people. And I think that what's important about that is that people can really see their own experiences in each of these media stories, right? Everybody knows someone who has been challenged with a medical bill or has a neighbor or a friend that is frustrated or challenged with a diagnosis or the cost of care. So it really has sort of tapped in and kept this sort of center stage. But this work in particular has been significant. Next slide. And in general, people really care about the issue of medical debt. There have been an increasing number of polls across the country to ask people about what type of debt really they're focused on or think is important to address. And medical debt continues to rise to the top, not to be compared with other types of debt because every debt is different and creates pressure for individuals. But there is a lot of unity and agreement that medical debt is not the fault of the individual. It's really the fault of the system itself. And it's also something that people can really find relatable. So interestingly, that people also back medical debt relief, which has been something that has been exciting for us because we have a new wave of work at RIP Medical Debt where we've had the opportunity where counties and states have approached us to do medical debt work, most notably Cook County in Illinois and also Toledo in Ohio, where they want to leverage government dollars to do debt relief for individuals in their communities, knowing that this is a really important disruptor that can help advance public health, but open up a conversation about longer term policy change. And so a pollster after the Toledo work did a poll to see how people felt about medical debt relief and found sort of a lot of unity regardless of background around the issue of medical debt. Next slide. And this is just one of the tables from one of the polls where you can see that there's just generally a lot of agreement regardless of people's background around medical debt being a crisis, right? So, and also that medical debt is really something that is important and harming people every day, and people want action. Next slide. And it's important to realize too that medical just is another doorway to talk about affordability, right? As Priscilla highlighted, part of the reason people are feeling the pressure and how the landscape has really shifted, I think particularly over the last couple of years, is that people might have increasing number of opportunities thanks to the Inflation Reduction Act and other efforts to have access to insurance. But the question is the insurance sufficient? And is it a protective factor in mitigating the harm of medical debt if the out-of-pocket costs are so high? So in addition to medical debt being an important issue for individuals across the country, and they're seeing it in the media, it is a doorway to have a larger conversation about affordability. Next slide. And we've surveyed our own beneficiaries about these issues, and in particular about how people are managing medical debt in their everyday lives. And this is a survey, it's some survey results from our own beneficiaries that we abolished debt for. And a number of them are commenting on the fact that they're feeling the pressure, they're carrying heavy medical debt, right? There's a number of people that are carrying medical debt in the thousands of dollars. And really that's creating a lot of pressure for them to either pick up new jobs or to borrow money from family or friends, to use up all of their savings or cut back on really the basic needs around food and housing and other household items. And then we have, a significant number of people that just can't pay it all. Next slide. So there's really a lot of momentum as we see across these different polls and around the sort of uptick in media presence around medical debt, that there is mounting pressure on decision makers across the country, regardless of their level of government, to take action, right? And most notably, there is a lot of pressure and conversation about we've opened the door and expanded the door around access to insurance, and maybe even address some of the premium challenges that people face. But we also need to address the out-of-pocket costs, which include the deductibles and the co-payments. And that also includes prescription drugs, right? So part of where we're seeing momentum, obviously, at the federal level is to address the out-of-pocket costs around prescription drugs. It also leads to medical debt. I mean, for us at RIP Medical Debt, abolishing debt is a really important short-term intervention that garners support at the local level and can really be a source of power building to increase and build pressure for long-term solutions that really eradicate medical debt once and for all. And Jen is going to talk a lot about some of these really significant changes at the state level that are picking up steam. Next slide. But it's important to note, and I draw your attention to this work out of the Robert Wood Johnson Foundation and Harmony Labs, in that as we think about the polling and the messages in the sort of the media ecosystem around medical debt, and while there is unity, we have to also remember that we're in a very divided environment as well. And so people's values really differ. And so they've done some work in really understanding how people's value systems differ and how the message needs to be tailored in order to move people along the continuum of action to really taking steps to address medical debt long term. So really understanding what your audience is an important step in crafting your message in order to help move people to action. Next slide. And then we are engaged, just as sort of a preview, with our friends at the American Cancer Society and Leukemia and Lymphoma Society to do some work with Perry Undon, which is a messaging research firm, to better understand medical debt and medical billing, how it affects patients and their families, and craft some policy solutions for more upstream work as we think about how we build increasing momentum to addressing medical debt, particularly at the federal level. And we hope to release those results and share them with folks like you in early November. Next slide. And then finally, these are just some links, because I know the slides are being sent out afterwards, just around some of the research on our own beneficiaries that we've done and other policy ideas that we think are important for eradicating medical debt. But thank you for your time, and I will pass the baton to Jen.
Thank you, Eva. And hi, I'm Jen Bosco. I'm a senior attorney at the National Consumer Law Center. And I'm going to be focusing on what states can do to address medical debt. Next slide, please. So this is just a little about NCLC. We're a nonprofit organization that advocates for economic justice and fairness for low-income and other disadvantaged people. And we've been around for over 50 years. Next slide, please. So you're all probably came in being experts in the unfortunate statistics about medical debt, and we've had, you know, some in the previous presentations, and so this is probably just another way to say, yes, medical debt is a huge problem and a public health crisis, and that the impact is particularly disproportionately felt on communities of color. Next slide, please. So I'm in talking about what states can do, I'm going to start out by talking a little about the federal laws that are out there, the gaps in the federal laws, NCLC's efforts to put together a model Medical Debt Protection Act as sort of a resource for states, and then what some states have done since, and some of the good state initiatives that have been going on to address the problem. And I just want to say at the outset, we recognize that, you know, the two focuses of the model Medical Debt Protection Act, they're really kind of the consumer law piece of medical debt. And they really, you know, these are absolutely helpful reforms that really can help consumers who are dealing with the consequences of medical debt. But it's not the be all and end all. You know, Eva just pointed out kind of the range of problems that are creating medical debt and impacting medical debt that are related to, you know, health insurance coverage and the price of healthcare and so many other factors. So just wanted to, you know, just say up front, we know this, that NCLC understands, you know, this isn't the solution for all the medical debt problems. It's really a way to help mitigate the harm on folks. Next slide, please. So to explain about what states can do, I just want to step back a second to talk about the federal law and the gaps in the federal law that exist. So you know, as you're probably familiar with, one provision of the Affordable Care Act put in place some rules about financial assistance policies that have to be offered by nonprofit hospitals. And there are a number of requirements that the financial assistance policies have to be in writing, they have to be publicized. There are some language access requirements. They, in a somewhat vague way, limit the amounts that can be charged for healthcare services for people who qualify for assistance and are found to be low income. So those patients who qualify for financial assistance can't be charged more than the amount generally billed, or AGB as it's referred to in the law. The hospitals are supposed to make reasonable efforts to determine whether an individual is eligible for financial assistance. And if someone is, then there are some debt collection protections as well, and there should not be any extraordinary collection actions for 120 days after the first bill if the patient is eligible for financial assistance. And I'll talk about those collection actions in a bit. Next slide, please. So here are some of the more significant gaps in the Affordable Care Act rules around financial assistance and the related debt collection protections. First, it only applies to nonprofit hospitals. That's because this is sort of a requirement for hospitals that take advantage of nonprofit status. So for-profit hospitals are not covered at all by these financial assistance requirements in federal law. Other large providers, which might provide some similar services to what hospitals provide, like surgical centers, those are not covered as well. The Affordable Care Act didn't set any firm eligibility requirements or specific amounts of assistance to be provided. So there's that language about limiting charges to no more than the amount generally billed. But the Affordable Care Act doesn't say, if you are a person who, it has income of less than 250% of the federal poverty level, you should qualify for free care. And if your income is more than that, up to 350%, then you should qualify for, 75% discount. There's nothing like that in the Affordable Care Act. It's all left up, not even to the states, it's left up to the hospitals to put those guidelines in place. And, as a result, and I guess as a result of the fact that this is something that the IRS has oversight over, there have been compliance issues. That seems to be improving a bit, but over the years, many hospitals didn't have a policy, didn't publicize it, didn't actually offer financial assistance to patients, still asked for payment even when they had a financial assistance and a patient was asking about it. I think the IRS, after years and years of underfunding, it's been a challenge for them to have the enforcement and compliance resources. I also just want to point out too, there is another federal law that it's not on the slide here, but the Federal Fair Debt Collection Practices Act limits some of the actions of debt collectors, and that applies to medical debt and other kinds of debt too. So just that is out there, but it mainly limits the behavior of the debt collectors. Next slide, please. So in looking at the gaps in the federal law, NCLC put together some draft language, some suggested language that advocates can use as a resource and tailor for their own states to help address some of these gaps in their own states. And about half of the states, I think, have their own state financial assistance law. So many states have, over the years have taken action, but there has been a lot more activity as of late. So I'm just going to walk through a summary of what's in the Model Act. And so the financial assistance policy scope is that there's language that would strengthen the financial assistance policies in state law, so that, for instance, we would recommend that in state law that for-profit hospitals also be required to comply, as well as nonprofit hospitals. The Model Act recommends that freestanding ambulatory surgical centers and other large healthcare providers be covered by this as well. Outpatient clinics and other facilities that are affiliated with nonprofit or for-profit hospitals would need to follow the financial assistance policy of their parent provider organization. And healthcare professionals who provide care in any of these settings would also be covered. Next slide, please. The Model Act also has some suggested language to limit some of the most abusive debt collection practices, and would prohibit civil arrests, or which sometimes in different states are referred to as body attachments or capias warrants. And civil arrest warrants are sometimes issued when somebody, when a patient has been sued in court for a medical debt, and you know, they may have a default judgment entered against them because they didn't show up. And so if the patient hasn't, or defendant hasn't gone back to court, then sometimes a civil arrest warrant is issued, and that happens in many more states than you know, than you would expect. Foreclosures on homes is prohibited. The act would also has language to prohibit garnishing wages for medical debt, garnishing, intercepting tax refunds at the state level, garnishing bank accounts, pension accounts, and that sort of thing. And and those are all considered extraordinary collection actions. There's further language in the Model Act that any other permitted extraordinary collection actions, there would have to be a delay of 180 days plus 30 days notice before they could be used. And notice would need to provide another chance to apply for financial assistance. And all of these limits would apply not just to the provider, but to the debt collector as well. Next slide, please. Which is on the next slide. So the protections would apply to debt buyers and debt collectors when they are collecting medical debts. And providers and debt collectors would also need to give patients detailed receipts of their payments as proof that the debt had already been paid or discharged. And there are also limits on the family responsibilities to have to pay for the medical debts of a spouse or a parent. And we're working on an update right now. It should be available pretty soon. And some of the changes we're making are a rule saying there could be no interest on medical debt and no credit reporting of medical debt. That's not what the current version says that you'll see on our website, but the forthcoming update will have that. Next slide, please. And just quickly, I'll say there are enforcement provisions because you can have great protections in place, but if a patient can't use the law themselves in court, that makes it that much harder to enforce. So there's a private right of action and also enforcement power for the Attorney General or other state agency. Next slide, please. So I just wanted to get to some examples of some of the different measures passed in a number of states over the past few years, and it has been exciting. I think a lot of the activity in the states, you know, some of it has been spurred by the media coverage that Eva was highlighting in her presentation. There's been great reporting, you know, from Kaiser, from NPR, from a number of other outlets, from New York Times, Washington Post, and a lot of local media outlets about medical debt and about abusive practices. There's also been, you know, from many organizations and, you know, from the CFPB, there's been data analysis and some good reports that really lay out the parameters of the problem. So Colorado passed a number of measures and they're listed here. Colorado actually they sort of stepped out ahead of many of the other states by preventing credit reports from reporting medical debt, and prevents creditors from representing that medical debt can be reported. There are, you know, another law limits facility fees, and there's another provision that says that hospitals not in compliance with price transparency laws can't pursue patients for medical debt. Generally, I think sometimes price transparency laws are held up as a solution to medical debt. I think that they are, you know, a very limited solution at best, but that can be something that is helpful in litigation if someone's challenging medical debt. So those passed this year in Colorado. Delaware just passed a new medical debt protection law saying that there would be no interest and payment plans for debts over $500 and a complete ban on civil arrest, wage and bank account garnishments and foreclosure by providers or debt collectors. Next slide. And Maryland has had a series of laws protecting patients. And this year there was further protections about the process for reimbursing patients who had paid for medical care in the past, but should have qualified for financial assistance. And even Texas had a law requiring itemized bills for patients. Next slide, please. The previous year in 2022, there was a successful ballot initiative in Arizona, which I think really does point to what was raised before, that these are popular reforms. This is really a widely shared concern, and everybody probably has someone in their family or someone close to them who's been affected by medical debt, and of course we're all healthcare consumers. So this really is something that hits close to home. New York prohibited liens entirely, so not just foreclosure on liens, but even issuing a lien on primary residences, and prohibited wage garnishment for medical debt, and those are great consumer protections there. Vermont had not had its own state financial assistance law, but they adopted one recently and also prohibit large healthcare facilities from selling their medical debt. Washington State had good laws in place previously, but made them even better and expanded their state charity care law recently. Next slide, please. And then here are just a few of the 2021 changes. So California had again already had a good financial assistance policy at the state level. They improved it. Maryland really created broad financial assistance rules and debt collection protections, and New Mexico as well did something similar. And next slide. So there are others. Those were just examples of the states, of some of the states that have passed state laws. There's actually a much longer list. So what I've included here are just some resources that if you want to take a look for more information about some of the things I talked about, here are some reports that NCLC has put out. The Ounce of Prevention report summarizes the state financial assistance rules, for instance. The Model Act is there, a recent report on medical credit cards, and the Racial Wealth and Health Gap report by my colleague Bernita Haynes is really excellent. Next slide. If you are a litigator who is defending clients who have medical debt, this is something that I used when I was in practicing at Health Law Advocates, and it was very helpful at the time, and I hope it continues to be helpful to advocates. So this is the collection actions manual that NCLC puts out. There's a long detailed chapter about medical debt and different defenses to medical debt. And next slide. And here are just some additional resources, a link to the CFPB materials on medical debt and their reports, a new report from Commonwealth Fund on state protections against medical debt, the University of Arizona scorecard, and just also a plug for our friends at $4 who help people to apply for charity care. And thank you. I hope I didn't go too much over. Oh, and yes, so I will hand it over to Dr. Shah. Thank you.
Hi, everyone. I'm going to talk a little bit about what we're doing in Los Angeles County in our Department of Public Health on medical debt. Thanks for having me here. And just want to acknowledge that RIP and NCLC have been really great advisors for us. So lots of lessons learned from work that people have been doing for a much longer time than us. Next slide, please. So I want to talk a little bit about, what we think of as healthcare harms, of which medical debt is a prominent example, and the role of public health in terms of from a institutional perspective. So health system regulation is a core public health function. It's one of CDC's 10 essential public health services. It's typically not been undertaken really at the local level. It's usually been sort of state and federal health departments that have been involved in this. We know our largest harms come from most frequent exposures, and that's really the regular healthcare system and its financial repercussions, and not so much, outlier health scams and fraudulent products. Although they are important, they are not our largest harms. Our healthcare partners are essential and generally well-meaning, but they do respond to policy incentives. And I think us as a Department of Public Health, it's our job to shape that environment. Again, typically it's been in the realm of state and federal policy, but there's many challenges compared to local public health. At those levels, you have more actors, so there's greater coordination complexity. You have more veto points, so there is increased leverage for lobbyists. And you have a lot of appointed, I think, positions, and so there is possible regulatory capture. Next. A little bit about what we see as, the value that a population health perspective brings to medical debt compared to current remedies. And, everything's supplementary. So the current remedies are very important. But we, in our lane as a public health department, our approaches, our expertise is a little bit different. So rather than sort of post hoc remedies, once you acquire medical debt, we're very interested in prevention. Legal remedies, including torts and bankruptcy, we really want to focus on surveillance and research. Consumer affair models and sort of client navigation, we really want to do organizing and partnerships. And then tax agency and status, we have other means of regulation and enforcement. Next, please. So why LA County? There's a few unique features here in our jurisdiction that I think are helpful, but they may, other jurisdictions have their advantages and some may share this. So we're fortunate that we had an existing mandate from our board through a healthcare consumer protection unit that coordinated with consumer affairs, although the focus was very much sort of health harm outliers such as fraudulent products or scams. The other unique feature in the county is that for many years, we have been delegated by the state to inspect and license all of our healthcare facilities. And so that is, I think, an entry and a point of leverage in working with our healthcare partners. We have a large canvas. So the county is 10 million residents, which would make it one of the largest states in the country. And we deal with 92 acute care hospitals alone as one key facility type. So I think what we learn here can be a blueprint for change across many other areas in the nation. And then we have wonderful executive support. We have strong department leadership that is committed to health equity. And we have in California, local health departments have substantial authority. We also have a broader, community and Board of Supervisors support for advancing health equity. Next. So we have a three-step strategy. The first is surveillance, which is the bread and butter of public health. So that's really answering the questions of, for any disease or health condition, the who, what, when, why, and where. And that information can then inform and also keep us accountable. Number two is organizing the local actors that are necessary to address medical debt. And then three is sort of the voluntary and regulatory actions that we intend to pursue. Next. So we were able to leverage the California Health Interview Survey, which has LA County specific representative samples to look at medical debt in our county. And we completed our baseline analysis earlier this year. The 2022 data will be out shortly this fall, but between 2017 and 2021, those numbers are not statistically significantly different. So 1 in 10 adults, around 800,000 residents are impacted by burdensome medical debt. So not just any medical debt, but the survey specifically asked about medical debt that causes burden to the individual or their household. What's surprising about this trend is that California has substantially increased insurance access in these 5 years. And we know that the uninsured still face the most burden, including in our data, but 3/4 of individuals reporting burdensome medical debt were insured. And we can see from this trend that insurance expansion alone, which is important, is not enough. Another surprising feature of our survey results was that individuals with Medi-Cal, which is the state Medicaid program, had twice the prevalence of burdensome medical debt compared to Medicare, which is really, really shocking because Medicaid, there's balanced billing protections and many other features different than Medicare. We're investigating this further and seeing what we can do to help solve it. Obviously, these are also some of our most vulnerable populations who are least well suited to take on the additional debt burden. Next slide, please. Just to put it into perspective, so public health, in terms of our largest population health programs, here's where burdensome medical debt stacks up in the county. So 5.8% of the county are current smokers, 8% suffer from asthma, about 12% suffer from diabetes. And so you can see medical debt is at or above our largest, most frequent health problems. Next. In terms of the amount, the total outstanding amount of medical debt, we don't really have a precise estimate because the last category was just greater than 8,000. But using sort of conservative estimates, it's greater than $2.6 billion as of 2021. And we have lots of reasons to believe that it's only increased since. Next. Again, as sort of hammered by previous speakers, the burden is really important. And in our data, our local data, in 2021, because of medical bills, half of the respondents took on credit card debt and half reported being unable to pay for basic necessities. What amount does it take to get to this level? Next, please. So for both of these situations, half of individuals who took on the credit card debt and half who were unable to pay for basic necessities, the amount owed was less than $2,000. So even what some of us may consider to be small amounts cause large problems. Next. I won't belabor this because it's been gone over, but again, it's wonderful to see this with local data that for people with even a single ER visit or hospital stay, even if they were insured, they were 2 to 3 times more likely to be burdened by medical debt. Those with burdensome medical debt, again, regardless of insurance status, were more likely to be food insecure, housing insecure, or forego needed prescriptions or healthcare. Next. Okay, so step 2 of our plan, organizing. So we did bring together community organizations and healthcare organizations, as well as other local governmental departments, and had a series of convenings where we reviewed the data, discussed ideas, solutions, barriers, and had a consensus process to develop an action plan. The coalition includes more than 21 community organizations, from labor to legal aid groups to just community representatives, 18 health organizations from our largest healthcare systems, our key health plans, and then related government offices. With this group, we were able to develop strategies that, again, led to an action plan for us in the county and will inform our work at the department level. Next. One element of the action plan that we decided was very important was additional data collection. So similar to other jurisdictions, specifically, we're interested in developing local ordinances to require the collection and making public data on individual level debt collection. So in the way a case of tuberculosis is reported to the health department, a patient sent to collections would be individually reportable, as well as aggregate reporting on financial assistance activities. Our coalition believes that this will increase transparency for healthcare systems, for the government and community stakeholders, as well as visibility to track progress on relieving medical debt burden. Next. Another action plan element was improving financial assistance. Of course, NCLC has really, I think, developed wonderful best practices around this. And so we are actually undertaking a detailed analysis. We've created a code book for analyzing hospital financial assistance policies as well as their financial assistance applications. After our analysis, we want to work with our coalition to develop a model policy and a model application to be adopted by everyone in the county. And finally, we're working closely with the state of California on AB 1020, which Jennifer already noted is an improvement on existing California law on financial assistance. Starting in 2024 has enforcement mechanisms, including financial penalties. So currently we're working with the state on the rulemaking around the new AB 1020 provisions and figuring out how to best both share bidirectional data with the state as well as make referrals on behalf of consumers so that the entire process is not consumer driven, especially when many impacted consumers are not necessarily well equipped to submit their own referrals. Next. Sorry, next slide, please. Oh, wonderful. And then, oh, one slide back, I think. I'll go ahead and speak while we're getting the right slide up, but if you can please go to the previous slide. Yep, so our last action plan item that I wanted to discuss, which really is inspired by the work of RAP Medical Debt, is undertaking medical debt relief at the county. We are hoping to create a debt relief fund to purchase and retire county residents' medical debt. Based on our local data, as well as obviously what we've learned nationally, this is really a rapid anti-poverty, and for LA County, where homelessness is a major issue, and anti-homelessness impact for hundreds of thousands of county residents. It's a great public-facing element of debt relief that I think goes hand in hand with the longer-term prevention efforts we would like to undertake. And then last slide. So in summary, medical debt is a public health problem. There are benefits to a population health approach. And then I really, want to emphasize this is, it takes the community to work on medical debt, but we believe there's this benefit from having an institutional home. And I don't think it's been clear what that is in any given local jurisdiction, and it may vary. But I think regular public health programming and public health departments are one such appropriate institutional home where you can really sustain focus. I think at state levels, it's often been attorney general's offices, but I think there's advantages and disadvantages to different institutional homes. Local action can supplement state and federal efforts. I don't think this all has to, we don't have to wait for Godot, and collective action remains critical. So I'll end there. You can find out more at our medical debt program page. Thank you.
Great. Thank you so much. That was such a comprehensive overview of, the major issues, just really hammering in the different dimensions in which medical debt is a public health crisis and the various social determinants of health that are impacted. Daniel, you can go ahead and stop sharing the screen so that we can see everyone. I'm just going to go first come, first serve basis through the Q&A, and then I'll go to the chat to make sure everyone gets their questions answered. I believe this first question was directed more towards Priscilla and Eva, but anyone can feel free to answer. So the first question is, are you doing work or are you aware of anyone addressing medical cost transparency?
Sure, I probably should have thrown that into the federal landscape slide, but the price transparency rules at the federal level are still sort of evolving, and the Biden administration has continued that policy from the Trump administration. I will say that what is interesting is Colorado, that has tied some of the hospital transparency requirements to extraordinary collection actions, so that at the state level, as part of their medical debt legislation, is if you want to use ECAs, then you also need to make sure you abide by the hospital price transparency rules. So there's still not great take up on those federal rules, as probably people know. So I think it was an effort to make sure that it was continuing to be center stage for hospitals around the prices of health services.
And Priscilla, it looks like you might have something to add.
No, I didn't. I was going to say I don't have anything else to add to what
Okay.
Ava has said. That's all that
Okay.
I wanted to say.
Great.
Quite comprehensive. Thank you, April.
Yeah. So the next question is, why does it continue to fall on providers to get payments from patients who are uninsured? Have you had any luck in getting payers to own up to paying for their covered members?
So I'm going to throw myself in again, but it is interesting that this was actually, so if you, the American Hospital Association actually supports this change and shift in policy, which would be that the insurers would be responsible for collecting these out-of-pocket payments and not the hospitals themselves. It is the hospitals find themselves in a frustrating position of both trying to help patients get well, but then also perhaps harming patients by pursuing unpaid medical bills at the same time. So this has been a frustration that certainly they have voiced. I think that people need to sort of step out of it for a moment and think about, well, how do we hold the patient harmless, which should be our sort of, driving mantra. And so it just sort of, it's like hot potato, right? It's not really solving the issue, which is that people can afford these hot out-of-pockets and high deductibles anyway.
Great, thank you. And I believe the next question came up during Jennifer's presentation. So the question is, do we know how the IRS enforces 501(r) rules? How do you even report non-compliance? And for those of us who aren't familiar with 501(r) rules, if you can provide a little explanation.
Sure. And I should say hi, Shelley, and thanks for that question. So the IRS 501(r) rules, those are the Affordable Care Act regulations about the financial assistance policies. But since it's administered by the IRS because it's part of the rules for nonprofit organizations or tax exempt organizations, that's why it falls under the IRS. And I mean, I wish I had a better answer. I think when I tried to bring a complaint to the attention of the IRS, I sent it to they have an exempt organizations department, charities and nonprofits. So I sent it there and elsewhere and didn't really get any response besides an acknowledgement that it was received. That was a few years ago though, so I don't know how things might be shifting. I think generally, the IRS looks into complaints or maybe does compliance review with hospitals. As far as we know, there've only been, I think, 2 hospitals where they lost their nonprofit status and one that voluntarily gave it up as a result of the IRS looking into their practices. But there are, I think, every couple of years, there is a report that the IRS has to make to Congress about their activities in that regard. So I wish I had a better answer for you, but that's kind of where we're at right now. Oh, and there is no private right of action. So a patient can't sue to enforce it. Should have said that at the front.
Great. And I believe this next question is also for you, Jennifer. Why are non-hospital physician practices exempt? Many of those do not have financial assistance programs and yet can result in significant bills for patients.
Yeah, it's a good question because, there are all kinds of healthcare provider practices that can cause medical debt. We hear of a lot of debt related to dental practices, for instance, and they're not covered. It's really, I think just the way the rule was drafted, and it was based on a previous requirement for hospitals as well. And there's just kind of always been this in place for nonprofit hospitals. There's been at least some requirement for charity care. So it wouldn't generalize to other providers who aren't hospitals unless the state puts it in their state law. And that is what we've seen in a few of the state laws that that I summarized in my slides, where they have also adopted that section where that says that the law will apply to large healthcare providers, and there's usually a financial threshold for how large.
Can I just
If
add one more, oh, go ahead, Dr.
Yeah,
Shaw,
go
you
ahead.
add first.
Well, no, I was just gonna say, looking at it from the enforcement side of it, it's already challenging enough to monitor and keep, let's say one type of facility, hospitals, in compliance, and there's far fewer hospitals than there are practices. So I think it would be operationally difficult, and it's, sort of the Willie Horton rule, you rob banks because that's where the money is. Hospitals are also, even though other provider types are not unimportant, it certainly is where the bulk of medical debt is.
But I would also argue that, as an organization that purchases debt in bulk, there is quite a bit of provider debt to purchase, which we do, and it is increasing. But also think about how, a lot of providers, when you go to the hospital and you get a service, that you're going to get a bill from the hospital, right? But you're also going to get a bill from the provider. And what we often see happens is that providers will opt out of financial assistance policies, which is something that they can do. So even though you might think that it's as easy as you walking in the door and I qualify for financial assistance, you might be able to you might get charity care from the hospital bills, but you're not maybe from the providers that have opted out of that financial assistance policy. So, I totally agree with you, Dr. Shaw, that it's such a monster problem. But one thing that we think that would help is, and would certainly help hospitals, is if all the providers that provide services in that hospital setting also were required to be a part of their financial assistance policy.
Yeah, thank you. That's really great. I'm just really highlighting how complex it is and how complicated it is when it seems like it should be simple, but there's all these factors that just as a patient, someone seeking medical care, that you're not going to be aware of or even thinking about at that time. So the next question, I think anyone could answer, and I think it kind of relates to the idea that Priscilla, you had mentioned, where medical debt is a type of debt that, we don't choose. So even if we know that it might be expensive or whatnot, we might still have to choose it, right? We can't just say,
right.
I'm not going to get this. So I think this is what this question is relating to. So the person says, isn't cost transparency and surprise legislation code for victim blaming? So I think maybe the idea that if people knew what they were going to be charged, then there would be some choice there. And they follow up and say, do we have data on whether or not knowing how much this is going to hurt changes debt outcomes? Certainly it changes health outcomes. So anyone who feels moved to answer that question, go ahead.
Can I just mention, I guess, with the cost transparency issue, I touched on it in my presentation. I tend to think that the price transparency laws, while very well intentioned, the concept of being able to shop for your healthcare and save money and avoid medical debt that way, I think it looks like we would pretty much all agree that's not. Unfortunately, it's not an effective solution, and I know a few states have done some analysis after they passed cost transparency rules to see if they were effective, and it was not shown to be a good solution for consumers.
Thank you. So turning to the next question. Are there good data sets for studying medical debt at the state level? For example, amounts, provider types, services types. And the second question is, have any states with stronger financial assistance policy regulations tried to measure the impact of those policies?
I would say Dr. Shah's approach is one of the best we've seen in terms of gathering data to do surveillance, but there is a huge gap in data in understanding medical debt across the country. The National Health Interview Survey has a question, and so does the Census Survey, but it's pretty limited unless people have made it into collections.
Can I jump in and in answer to Kara's question? Hi, Kara. And I think we have used the Urban Institute data quite a bit. Their Debt in America series, they have sort of a map of the US, and you can look by state or by county at levels of medical debt, but it's been based on credit reports, so I think that's going to be difficult to use increasingly. There are a few state studies. Maryland had a really good study about medical debt, financial assistance, debt collection practices. North Carolina has had some. I saw North Carolina was mentioned in the chat. Their treasurer's office did some good reports. There's a report about Texas, even Virginia. There have been a bunch. But in terms of one cohesive database for all the medical debt information by state, I don't really know that anyone's been able to pull anything like that together. I think though the Urban Institute is looking into the second part of the question. I think they are beginning to do some research into what has been the impact in some of the states that have passed some of the recent medical debt protection laws. What's been the impact on consumers?
Just following up on that, one of the questions that came up for me during Dr. Shah's presentation, and I think it came up in a couple of presentations, is people taking on credit card debt to pay for medical debt. So I just wonder if any of you have it seems like that would make it harder to measure medical debt because it's hiding out in credit card debt. So do you guys have any data on that, or just thoughts on how to kind of make that more visible?
I can just answer from our analysis, and you're absolutely right. And not just credit card debt, but for example, informal loans from friends and family, many other sources of debt that won't appear on the books. So I think, Kaiser, when they did their national medical debt survey, they really focused on this, was just asking the individual. And so you can't use credit reporting systems, but by just doing population representative surveys and surveying individuals, you can get at that. Those are, however, time-consuming, expensive, and not easy to do. And so there's limitations, which is why, again, I think this question and your question are really building the case for surveillance as a foundational approach.
Thank you. So I'm moving on to the chat, and I just want to highlight a couple of questions and resources that have come up there. So just to highlight, Daniel Friedman is interested in connecting on these issues. So for anyone that's interested in connecting, you can reach out to him. One of the questions, and Dr. Shah and Ava and a couple of other people have responded, was in the chat, was, are you able to track litigation pursued by large medical providers such as hospitals? It seems hard to track given that they use different names as the plaintiff. So I know there's some resources in the chat, but if anyone wants to briefly speak to that.
We don't. It is really hard because there are different, the providers, there could be different names. Then the debt collectors are probably filing majority of litigation, and so that's going to be all different names. You wouldn't necessarily know from the name of a case in court records if something was medical debt or not, unless you knew the debt collector only collected medical debt. I think there is research going on though to try to get some more detail about that nationally, but definitely a heavy lift.
Yeah, there are
Okay.
a lot of data scraping efforts going on to try and do exactly what Jen said. And just to highlight too, that an area I think that's unexplored is that you can't tell who, as Jen pointed out, that if a debt collector is doing medical debt or not. So there's not, when you look for a list of debt collectors, you can't segment by whether or not they are focusing on medical debt. And that can be challenging and challenging for that kind of search as well.
Thank you. And so I think we'll do we're at the top of the hour, but I just want to get to let's see, we have 2 more questions. So if you have to leave, no problem, but if you can hang out for another minute. One of the questions is, what is the role of surprise billing in the amount of debt among publicly funded insured individuals or families? So any thoughts on this? If I think what it's asking is, how much of that debt incurred is the result of surprise billing, and if the data is not out there, that's also helpful to know.
I think it's a concern that Medicaid patients would be billed, right? And so, as Dr. Shaw raised in his presentation, whether or not there's data that tracks that, I'm not sure, but it's certainly something that could be monitored and institutions could be held to account.
Yeah,
Okay.
and we don't have data on it. We are concerned about it, and it depends what you mean by surprise billing as well. So one of our hypotheses around our Medicaid medical debt is that the state has transitioned away from state fee-for-service Medi-Cal to managed care Medi-Cal contracts, including a number of private players. And when you have these narrow networks, individuals may either seek care outside of the network because they can't access care within their network, or may inadvertently receive care outside of the network, not be aware that it's not covered, and therefore end up in medical debt.
Thank you. And our last question is, do nonprofit hospitals report how much money is assigned to debt collectors?
I think that some research efforts have gotten information about particular hospitals, like some of the media exposés, but I think there's not like kind of a general reporting requirement.
Thanks so much. And with that, we'll wrap up. I will pass it to Daniel to close us out.
Yes, thank you everyone for your participation in today's webinar, and thank you to our panelists and speakers for an amazing webinar today. Just a few final notes. All attendees will receive recording of the webinar as well as the slides that were used in about a week after the webinar. It will also be posted on the Network for Public Health webinar site. It'll just be under the medical debt as a public health crisis page. But that wraps up everything for today. So thank you all for attending and have a great rest of your day. Thank you all.
Thank you.